we want to start today, and before starting, we would like to thank you very much accepting our invitation and coming to this session. So we will start. Myself, I am Ahmed Shweki, the General Manager of Virus. My role today is to talk about the mission of Virus. Usually I spend hours, but today I am going to spend a couple of minutes. So today I start with the slide of having this fish. Not to talk about the fish, but to talk about a story of a person who visited one of Asian countries. And he observed that the food in the fish in the fish market, in the restaurants, it's without head and tail. So he was curious enough to ask why they are cutting the head and the tail. So he was asking more and more people. He is not getting an answer. He went to the fish market to get an answer, no answer. Eventually, they told him, you need to see a lady. She is more than 100 years old. So she should have the answer. And eventually he asked her and she answered. During when she was 20 years old at that time, they were having very small cooking bowl. When they want to cook the fish, it was small. So they were cutting the head and the tail. So that's why they were cutting the head and tail. And until today, they are doing the same. This is actually in our industry, that what is Virus trying to do is not to copy and paste or to do just a business of having machines or boxes, rather than to add value to the community where we are living here in lovely UAE country. So what we are trying to do is really to contribute to the healthcare community, to bring the innovation, to be aligned with the new approach happening in the worldwide, to be maybe very small part. As a commercial company, you are the expert, you are the physician, you are the one who is saving life and improving the patient healthcare system. We are indirect, but even though we want to contribute with you. So what we are trying to do is to have the innovation that is aligned with the new approach and practice, and to be part with the education, with the awareness, and having today, with many thanks to Diasorin, having the scientific people, having Dr. Catherine, she is coming from NHS, to talk about some scientific topics. You know about it. It's kind of refreshing. It's about an experience in different countries, what is happening for new approaches or current approaches happening worldwide. So that's it from my end. Thank you very much. So now my colleague, Ms. Rumi, she is going to give you just a few slides about Virus in a brief manner. Thank you.
So good evening, everyone. First of all, I'd like to thank you all for being here. Very nice faces. I'm so happy that all of you are here. We value your time, so it is our pleasure to have you here with us tonight. For those who don't know me, my name is Rumi Matar. I'm the Senior Product Specialist at Virus. And here I am tonight representing Virus as an advanced progressive medical company that is revolutionizing the healthcare sector. Our mission is basically to provide reliable and up-to-date solutions that we are trying as much as we can to power the innovation in the healthcare industry, as Mr. Shweki just mentioned. Before I begin with my presentation, I would just like to go through the agenda very quickly. Can you guys see it from me? Yes. Okay. So we will introduce virus and Diasorin, and then we will be talking about the HSV, significance of HSV and the molecular testing. After the coffee break, we will talk about the clinical significance of GI testing. Then we will talk about Diasorin molecular solution in general, and then we will have a Q&A session, wrap up, and finally enjoy our dinner together. I can say that Virus is working day and night for a future that is better than what we are living today. I can also say that our company is composed of a multinational team of almost 15 different nationalities, again working together day and night for a better tomorrow. We are promising 2 to 4 hour response time and 24/7 support through our hotline number. And I can proudly say now that we have successfully installed 137 different machines in the UAE in a very short period of time. And hopefully, after tonight's event, we will be able to grow even more, having you as strategic partners to Virus. Just before I start talking about the different, just before Diasorin will take over the stage, I'd like to just briefly introduce to you the different solutions that we have in Virus that would complement whatever molecular solution that is currently available in your laboratories. Starting off with, okay, so we have partnered with Grifols on the instrument called the Panther, which uses nucleic acid amplification testing for the detection of infectious agents from blood or plasma donations. Serology, Verclea Lotus, we have a chemiluminescence technology that detects a wide range of infectious panels. Semen analysis using the SCAScope, it is an automated semen analysis for the detection of and the diagnosis of more than 100 different parameters for fertility industries. Drug of abuse, we have partnered with Randox, which is a dedicated toxicology company, using their instrument called the Multistat, which many of you are familiar with. It uses the simultaneous detection of up to 21 different drugs for the same patient in the same run. Linearity testing with LGC main standard, the product is called Validate. What we do, these kits are used for verification of instruments and kits. So what you do, that we know that there are certain standards that every machine or kit has to meet. So what you do, you use these kits to make sure you are being aligned with the guidelines currently in the country. For quality controls, we have 2 different companies from Versal and Randox. Versal, Total Ampliron are controls that use the kits, the controls directly starting from the extraction to the amplification stage. The second one is only Ampliron, which is also controls for DNA and RNA amplification only. And also we have from Randox, which is a very well-known and a leader in proficiency testing, product called QCMD for EQA testing, and also they have QGnostics, which also a lot of the team already are aware about, for third-party controls. NGS partnered with the Genes to Me. They are NGS kits for the diagnosis, the prevention, and also the treatment of genetic mutations such as cardiovascular, respiratory, cancer, and even neurological mutations. Laboratory information system is a LIMS system which helps any lab. It is very flexible and user-friendly. It helps laboratories with their everyday lifestyle working in the lab. Microbiology, we have partnered with Accelerate for 2 different instrumentation, Accelerate Pheno and Accelerate ARC. The Pheno is a machine that uses fast ID and AST technology. The ID, we can give a result within 2 hours directly from a positive blood culture using the FISH technology. And for AST, MIC, and phenotypic resisting, we are given a result within 5 hours using the morphocellular kinetic analysis. So by this technology, we are reducing the time to result from around 50 hours from conventional to around 7 hours. The second instrument from Accelerate is called the ARC. The ARC is a pre-sample preparation before adding your sample to the MALDI analyzer. So instead of having to wait 24 hours for the colony to add it on a MALDI, for example, you will have your sample ready to add it on a MALDI within 1 hour. And then finally, for our event, for molecular, we have 2 parts. We have the real-time PCR kits, which are considered as point of care, and also normal PCR kits. For the real-time point of care kits, Vivalytic, our first machine, where Randox also partnered with Bosch, and they manufacture an instrument called Vivalytic, which uses the biochip microarray technology for the detection of multiple analytes in 1 run. Second is Lysin MDX, our partners here from Diasorin, representing this MDX, which is an innovative and powerful thermocycler for the detection of different analytes. One of them is a direct amplification disc, which fits 8 patients. It's an 8-well disc. The second one is a 96-well disc, which fits around 96 patients in the same run. Next is the point-of-care instrument from Diasorin Luminex, which is called the ARIES. It's considered a sample-to-answer analyzer for multiple assays, and it's also considered a single-plex instrument. Finally, for only PCR kits, we have partnered with GeneProof, which is a high-quality CE-IVD company, which has a lot of different genetic assays and disorders, serious infections that you can run on. O&M Diagnostics, this is a very also interesting company which focuses on fungal infections only. So we are looking at Candida species, Aspergillus galactomannan, and so forth. These kits are done they are given for amplification, so you can get results for these fungal infections within 45 minutes after the extraction. Finally, from also Diasorin Luminex company, we have MagPix, which is also an innovative multiplexing instrument which uses the fluorescence technology for the reading of any of your any of the assays after extraction and amplification. So this is the last slide for the solutions. I would like to say that Virus believes in a healthy sector, and when we have a healthy sector, it means we have a successful one. So this is why we are working day and night to provide all of these services and technologies at its best, so that everyone can see the value of these instrumentations and these solutions for a better patient care. We are here tonight for the event of Diasorin. We are so excited to be here for Diasorin and Diasorin Luminex event, where they will be focusing on molecular solutions, especially GI and HSV testing. Here I am leaving the floor to Mr. Sami Ghazal, Diasorin. He will be representing Diasorin.
Yeah, thank you, Remy. Assalamu alaikum, everyone. And first of all, I just wanted to say good evening and a big thank you all for coming here tonight. We really do appreciate your attendance. And you know, for us, for us, you being here is part of our campaign in really trying to build awareness about the importance of molecular diagnostic testing. So a really big thank you all for that. And also as well for us, we've got a really special guest here tonight, Dr. Catherine Moore, who's a consultant virologist in the Wales Public Health. So we're really excited to have her here tonight, coming here to talk to you about HSV molecular testing and GI molecular testing. We did also a similar workshop yesterday in Dubai, so we're really delighted now as well to be here in Abu Dhabi with you guys tonight. So I know you're all very eager to get into the science, so I won't take too long, just to give you a couple of slides, give you an understanding about Diasorin, and what we stand for as a company and our values. So Diasorin, we've been around for about 50 years, Italian company, with a very Italian vibe. We're listed on the FTSE 100 in Italy, but at the same time we're still a very much family-orientated company. The real value of Diasorin and what we stand for is a specialty diagnostic testing company. This is the predominant focus of our company and the message that we want to give in the industry. We're continually re-innovating products all the time. The company's investing heavily to make sure that we're giving the most latest, up-to-date products available to laboratories, diagnostic labs in the industry. The company's broken down into two. So we've got our in vitro diagnostics, which is split between immuno and molecular. And then we've also got our licensed technologies, which some of you may have heard of the brand Luminex. I'll come on to in the next slide. A little bit about some of the key milestones. So we were founded in 1968. We actually originally started with the automobile company Fiat. It was part of, actually Diasorin was part of Fiat long ago. And then moving more to the most recent milestones, like in 2016, we acquired, that's when we really started to get into molecular diagnostics, when we acquired Focus Diagnostics. And then taking us all the way up to 2021 with the big acquisition, the first biggest acquisition of Diasorin, of Luminex Technologies, which we bought for $1.8 billion. And what really triggered that for us was obviously with the pandemic, the market trend is moving towards molecular diagnostics. It's starting to get into the fashion, if you like, in the lab industry. So we wanted to be a part of that, which is one of the reasons why we invested so heavily in molecular technologies. So we've got a worldwide presence across in North America, Europe and Africa, and the rest of the world. We've got over 3,300 employees as well. Just a little bit about the immunodiagnostics. I'm sure some of you know about our immuno products, where we've got basically all different types of technology to fit any size lab. So I won't go into the full details of that. And molecular, a bit later on today, my colleague Chiara Saletti will give you a little bit of an overview of our molecular portfolio offering. So she'll spend a little bit of time with you then. It's the breakdown of the company. Our company, we're doing approximately $1.3 billion sales per year, and that's broken down but with 8%, which is the licensed technologies, where we make OEM products for companies like Thermo, also as well Biorad, and then we've also got, and then it's broken down with immuno as 57 and molecular at 35. So it's really important as well, for any medical diagnostic company that want to really operate in the region, they also need to have resources on the ground. And Diasorin has invested heavily in the Middle East. We just opened up a brand new office over a year ago in Dubai Science Park, where we have a training centre to train any of our customers, our distributors in the region, to make sure that they are up to speed and certified on our technologies. And really the goal is to make sure that we're giving you the right level of support, the same kind of support that you would expect to receive in direct markets. For example, like in the UK, where Diasorin has a direct subsidiary, or in France, Germany, whatever. We want you to receive that same level of care and same level of support as in those markets. So this is my team, basically. I've got two sales managers. Tonight I've got my product manager, Moeen Barakat, some of you may know him, and also Dr. Imad Aldi, who's our sales manager for the UAE. And we also have a regional service manager as well. For us, we're really, really pleased to be working and partnering with Biorus. We go through a real stringent process to select the right distributor to really represent our brand in the market. So it was really key for us to find a distributor where we felt was specialised and has the right expertise to really focus in molecular products. So we are really delighted to work with them, and we want to give them a real massive thank you for tonight, for putting this event together, which I really hope you do find valuable. So thanks very much for your time, and enjoy the workshop. Thank you.
Good evening, everyone. So my name is Amanda. I'm the Senior Medical Scientific Liaison at Biorus. It's our pleasure to having you all here with us today for this interesting workshop. Please allow me now to introduce Dr. Catherine Moore from NHS UK. She will be now giving the first part of the presentation on HSV molecular testing. Thank you.
Thank you. So I should just get on to things. So this is me. So I'm Catherine Moore, and I work for Public Health Wales. We're part of the NHS. Wales is, you might or may not know, is devolved. So our health service comes under Public Health Wales alone. And today is St David's Day in Wales, so there's a bit of a celebration going on. So happy St David's Day. So last year I got contacted by Diasorin to come and do this workshop on HSV. If you Google my name and Public Health Wales, you will come up with a lot of publications on RNA viruses and respiratory viruses, because those are my areas of expertise in terms of research and development. But as a consultant virologist, HSV is what we would call one of our bread and butter viruses, something that we really need to understand, something that we need to understand the impact in our patient group, and also understand how and why it causes the problems that it does, and how we might manage those going forwards. Since about 2005, we've been testing most of our HSV cases using molecular techniques, so we go way back. Part of my job role is in the development of molecular services for Public Health Wales, and HSV was indeed one of the first viruses that I put under molecular diagnostics. And so what I'm hoping to do is not teach you anything about HSV. I'm going to remind you about HSV and about why it's important, what it does to patients, and also why molecular technologies might be the way forward in terms of helping us manage these cases. So this is my content. So we'll do a bit of the virology because I'm a virologist. We'll talk about some of the laboratory diagnostic methods that have been used, so a little bit of a refresher of what some of us might have done in the past, and then also what we're now doing in the current. And then I'm going to talk about 3 particular areas. So central nervous disease, infections in pregnancy, and infections in the neonate. And obviously 2 of those are pretty much, concurrent. If you manage one, you're managing the other as well. And then I'm just going to summarise that. So, if we just to remind ourselves about what the herpes viruses are, we know that they are ubiquitous in nature. If you go into any mammalian or avian species and you do surveys, you will find some form of herpes virus within that species. They're ubiquitous in nature. They're absolutely everywhere. They belong to the herpes viridae family, so if you're doing any exams in virology, it's useful to know all your family groupings. All of the viruses are enveloped. They're double-stranded DNA viruses, which makes them a perfect target for any molecular test, because as we know, PCR requires DNA to do their amplification. So in humans, there are 8 herpes viruses, which are for us, so they are known as the human herpes viruses. And then there's a 9th, the cercospitine virus, herpes virus 1, or B virus, which is a zoonotic infection. As you know, if you get bitten by a macaque monkey, in some countries, macaques have this virus as part of their own zoonotic repertoire, and they can transmit to us. It's incredibly rare, but something that we are aware of. They all share this ability to become latent within the host after their primary infection. This is what makes them such a challenging group of viruses to actually manage in the host going forwards. And they reactivate on and off throughout life. So following your first infection, you can see reactivations occurring all the way through your life. So let's look at classification, and I did put this slide up really because I've got a nice picture, an electron microscope picture of the classical herpes virus. So you've got the capsid in the centre, surrounded by the envelope in that classical fried egg shape. So if you ever see that in an exam or in any teaching, you know that we're looking at herpes viruses. They're all based on, so they're subdivided into 3 subfamilies based on their genomic and biological characteristics. So the alpha herpes viruses, which are the ones I'm going to really concentrate on for the later parts of this talk, include HSV 1 and 2 and VZV, so the other virus that we see regularly throughout life, the virus that causes chickenpox and shingles. Then we have the beta herpes viruses, that include cytomegalovirus and human herpes viruses type 6A, 6B, and human herpes virus type 7. So cytomegalovirus we know is a common infection throughout life and is a particular concern in pregnant women. I'm not going to talk about that today, but it is another virus that, again, molecular technology is being used primarily as their front diagnosis. The human herpes viruses 6 and 7 are associated usually with diseases in childhood, and we know roseola, particularly in the under 5s, where you have this high temperature and then the temperature breaks and they get this florid rash, which often is confused with measles. And then at the bottom we have the gamma herpes viruses, which include Epstein-Barr virus and also the Kaposi sarcoma virus, HHV8. And I'm not going to dwell on those too much, except to say the EBV and Kaposi sarcoma are obviously associated with malignancy, and more recently EBV has been associated with an increased risk of multiple sclerosis. So as a group of viruses, they're not just our bread and butter, sometimes they're the backbone of our service when we're actually managing patients in clinical virology. So let's just focus in now on HSV 1 and 2. And basically, we classify HSV infections as your primary infection or your first meeting of the virus. So this is when you have no prior immunity at all, you've never met this virus at all in life. And this first infection, let's remind ourselves, can be asymptomatic. So you might not have any symptoms at all, or even mildly symptomatic, so you may just have a single lesion. Or indeed you can see, particularly in young children, quite severe gingivital involvement with face and eyes affected as well. So you can see from one extreme to the other, but often it is asymptomatic, so you don't actually know you've been infected. After this primary infection, the virus then goes into a latent phase, and now you have immunity, so you can measure it using immunoassays, but you also have the virus sitting in your nerve cells ready to actually become reactivated at some point in future life. And often, depending on where your infection arises, you will usually find the virus in your trigeminal or your sacral ganglia, depending on whether you have an oral infection first or a genital infection, or either or, so you can have it in both. And then recurrent infection is a periodic event when the virus reinitiates its replication, so it reactivates within those nerve cells. And this can lead to disease itself, so you could find yourself with a rash, or you can find yourself with a cold sore or whatever, or you can just have asymptomatic shedding. So this is where you can find the virus in your mucosal layer or in your saliva or in your genital tract, but no evidence of infection if you were to look for signs of clinical disease. And this is all despite the presence of immunity. So you can measure your immunity, and there could be really good levels of IgG present in that sample, but you can still get this recurrent reinfection throughout life. So let's talk about primary infection and transmission infection. And really the reason I'm going into this is because there are a lot of myths about how HSV is transmitted. There is this presumption that you need to be overtly symptomatic to pass it on. Essentially, both viruses infect the host in exactly the same way. So it's inoculation through the mucous membranes or abraded skin. So even just having a scratch or a slight abrasion on your mucosal membrane will allow the virus to entry into your local cells. And then you have this local replication which occurs in the dermis and epidermis of your skin. And this is where you can sometimes see that localized lesion just starting to appear, or even more spread out in your mucosal levels. And this is generally from infected host to susceptible host, but let's not forget at this point auto-inoculation. So this is an issue particularly in young girls that we see, where they have their first infection in their mouth, and they're for whatever reason touching their mouths, and they touch their genitals, for example, they're going to the toilet, and they can actually transmit from the mouth to the genitals in that way. So this is auto-inoculation, and you can see the same thing from the mouth into the eyes as well, where you get an ocular infection associated with that. This is something we see quite frequently in young children. So what happens then is the capsid of the virus, so you've got this local replication occurring in your dermis, but the capsid of the virus, so the envelope is removed, and that capsid then moves to your ganglia, where replication, seeding of other sites then occurs. So it can go through from the ganglia into other sites. So although your infection might happen in your mouth, you may sometimes see crops of infections perhaps happening on your neck or around your ears, or in unusual places, not necessarily the site of location. So this is by your peripheral nerves. And you can sometimes see viremia, but it's not always a feature. So using the blood as a diagnostic tool is not always effective at this point, because the viremia can sometimes be quite transient, but it does allow reseeding of that virus then into other parts of the body. So latency, this is where we have the real issues with these viruses, because despite immunity, the virus just goes into a latent state. And this happens in the non-replicating sensory neurons. And like I say, for HSV1, usually because the infection is around the mouth, you would get latency within the trigeminal nerves. And for HSV2, if you have a genital infection, it will be in the sacral nerves. And then reactivation can often occur during periods of stress, just being very tired. You can sometimes see that reactivation occurring. Exposure to the sunlight can trigger some people. And then just having a fever or having another infection or being ill for another reason can also cause a reactivation at that point. It is unusual for us, for example, to see people in ITU for one reason actually having also a reactivation of HSV at the same time, which we can detect using molecular methods. So isolation of herpes virus in saliva and genital secretions in the absence of symptoms does suggest, so this is through periodic testing of people and some research that's been going on for a long time about trying to understand about recurrent rates of HSV, suggests that reactivation is dynamic. So despite your immunity, you can see reactivation happening quite regularly throughout life. and it is a frequent occurrence in some people. And some individuals, for whatever reason, they have this reactivation as a real problem for those. And these perhaps are potentially some of our super spreaders, so people who reactivate on a regular occurrence with or without symptoms. Maybe these are the individuals who are allowing that transmission to occur throughout the population. And actually, for some individuals, the severity is often similar to their first event, so it will always seem like they're having the worst herpes outbreak ever, even though they've had it in the past as well. And there's no real reason for this underlying in their underlying immunity. You know, they'll quite often go through to see immunologists, and there won't be any real reasons why they're having this level. And then obviously in your immunosuppressed population, we're seeing far more people who are immunosuppressed. Use of monoclonal antibodies for things like rheumatoid arthritis does bring an increased risk of reactivation, and again, often with symptoms which are as severe as their first event. So let's just take those points. So most infections occur from asymptomatic hosts. So evidence of lesions themselves is a poor predictor of rates of transmission in any given population. You just have to bear in mind, just because there are no lesions, it doesn't mean there isn't HSV in your population, because it can occur from asymptomatic hosts. Auto-inoculation is a real feature in this virus, particularly in young children. And this allows for virus from one infected site to another, so for example, oral to genital or oral to eyes, and so on. And reactivation in some individuals is far more frequent than in others, and that's in spite of good immunity. So it's no good just looking at the immunity to presume that somebody is protected, because in some individuals reactivation will occur regarding that. And so patient history, so if you ask a patient have they ever had herpes, and they say no, is not really a good indicator of somebody saying that they definitely haven't had HSV. So it's a poor marker for prior exposure. So let's look at some of the clinical syndromes, and you're going to see this slide twice because actually there's quite a lot of overlapping infections. So HSV1, the clinical syndrome. So right at the far side you have the sort of minor, sort of normal daily ailments that you have. You have your cold sores, and you have sort of like a first event in a child. So these are very typical presentations that we would normally associate with HSV1. Interesting, as we move along this way, you've got at the top there, so that's actually a photograph of a penis, a shaft of a penis with a genital HSV1 infection, and then underneath you've got eczema herpeticum, really quite a severe eczema presentation in individuals. And then obviously you've got sort of issues with the eyes, where the HSV reactivates in the back of the eye, or indeed you just get inoculation into the eye itself. Neonatal herpes, and then right at the end you've got HSV encephalitis, and I will talk about that in a little while. So HSV2, it's generally considered sexually transmitted. It generally has fewer syndromes associated with it, but there is a great deal of overlap. So you see over there you've got the genital herpes, but you can get cold sores. You know, we had this rule many years ago that HSV1 was associated with infections above the belt, and HSV2 with infections below the belt. We know that now with different epidemiologies that this is now changing. So HSV2 cold sores are now a feature. You've got it around the eyes again, so again without an auto-inoculation you can still see eye infections. And this is meningitis rather than encephalitis. It's more often associated with the meningitic picture. And then obviously at the end here you've got the neonatal infections as well, which again I'll talk about how our changing epidemiology is seeing this occurring more often. So differential diagnosis. So the question is, why can't we just diagnose this clinically? It's bundle obvious that this is herpes when you look at a lesion. Well, I would love to say that's true, but actually it's not. A lot of people come in and say, well, this is HSV, and when we ask for a swab, we get all sorts of different differential diagnosis. And MPOX very recently showed us how divergent some of the presentations are. So syphilis, the primary chancre for syphilis, we've had that confused with herpes. We've had enterovirus absolutely classically mistaken for herpes. It looks just like herpes herpeticum in some incidences. So children who are presenting with very severe dermatitis often have enterovirus, and usually it's one of the Coxsackie A viruses. And then you've got the molluscum viruses, molluscum, mpox and ORF, which all can present in their very early features, and people can mistake that then for HSV. And then right at the bottom, the greatest pretender of them all, which would be VZV, and in particular shingles, where you have a shingles rash erupting, and it's in an area where somebody's had HSV before. And it's also very common to see VZV and HSV2 in the same sample as well, so one will reactivate the other, so they sort of work in synergy. The CNS infections themselves has multiple alternative differential diagnoses, so it's actually very difficult to just presume that something is HSV, and that you should really be looking wider than HSV itself. But let's look at seroepidemiology. So, seroepidemiology, so just doing the immune levels of the population, consistently shows that rates of HSV1 infection is around 70 to 90% of the population at any given time. So the overall global burden then, just of HSV1, is around 3.7 billion people under the age of 50, so 67% of our global population at any one time will have evidence of HSV1 infection. The age of acquisition is where we see the difference. So this does vary depending on the socio-economic background. So poorer countries will see earlier acquisition compared to countries with a higher socio-economic things. You will see acquisition much later in life. Later acquisition is certainly an issue now in Europe. We're seeing much later HSV1 infections being reported. So first events not happening until late teens, early 20s for HSV1. We're not seeing it in the children. But by adulthood, if you did seroepidemiology across the world, you would generally attribute that the seroprevalence is about the same, so about that 70% to 90% in the whole world. For HSV2, there is far more variability. So the global overall burden is thought to be about 491 million people between the ages of 15 to 49 years. And for some reason, 15 to 49 is what they associate with being sexually active. You don't have sex after 49, apparently. And that's not really true, because what we're seeing now in Europe is that first infections can happen later in life as well. So we are seeing some pushing of that first infection into later life. So don't presume, just because there's an older person, that you shouldn't consider HSV as an infection at that time. So about 13% of the population at any given time will have HSV2. And sexual transmission does increase with the number of sexual partners. We know this. The more sexual partners that you have, the more likely it is that you're going to get any STI, so not just herpes, but any STI in general. And so your incidence ranges from 6% in pregnant women in Japan, when they've done the seroepidemiology there, to about 90% in the commercial sex workers in Central Africa. So you can see there's a huge diversity in range in the seroprevalence levels. Interestingly, when I looked, there is a paucity of data about seroprevalence from both of these viruses in North Africa and in the Middle East region of the world. So that's data that's missing from the total global. But we can probably presume that certainly for HSV1 we would be up there, because it's the same across the world. You just get to a plateau. So changing epidemiology of HSV does have some quite significant implications, because HSV1 in childhood protects against the more severe form of HSV2 in adulthood. So although it's not complete protection, there is some level of cross-protection between the two viruses. We know that HSV2 is found frequently in men, particularly those with more sexual partners, but infection is more easily transmitted to women, so it doesn't take much for a woman to become infected. So whilst men may be clear for a longer period of time, it would just take one event for a woman to become infected with HSV compared to men. Seronegative women, so those women who've never been exposed, are therefore at greater risk of first acquisition of HSV2 in pregnancy. So this is the virus which is most commonly associated with pregnant women and neonatal infection, although I will sort of give you some changes of thought with that, I hope. And then you get that increased risk of severity. But recent epidemiological studies, there's some quite nice data out there that does suggest that in certain parts of Europe, that due to later acquisition, HSV1 is becoming increasingly the most common type associated with genital infection. So don't presume all genital infection is going to be HSV2. There is quite a lot of HSV2 associated with that. It is often associated with fewer episodes of reactivation, and what we have found is that women who are infected with HSV1, as they go through life, their reoccurrence does drop off over time, and actually what you're trying to prevent them from is from getting HSV2 on top, because that then will restart the cycle. but it does offer then a clinical risk to the neonate. Treatment is really simple and widely available, and acyclovir remains the frontline treatment, and goodness knows how long we've had acyclovir in our bank of antivirals. And it's used for frontline treatment and prophylaxis of both HSV and VZV. Has very little role in the management of other herpes viruses. They don't quite work in the same way. It's a purine nucleoside analogue, and it's selectively phosphorylated. It has to go, so it's a prodrug. It has to go through 3 stages for it to become active. And the first of those stages is phosphorylation by the thymidine kinase associated with HSV and VZV replication. So it's that first drug there. And then after the first 2 steps, the phosphorylation occurs through cellular, so our own cells will then phosphorylate it further to allow it then to integrate into the viral polymerase and effectively stop replication at that point. Has an extremely high affinity to viral rather than the host cell DNA polymerases, so you don't see it, that's incorporation into our own cells as you might do with some of the other antivirals. Its bioavailability, however, is only sort of 10 to 20%, so you know that if you've got an acute HSV that you're treating, you're giving quite high doses of drug to actually ameliorate that infection. And in severe infections, we give IV acyclovir. Valacyclovir is being used more and more, including in treatment of in immunocompromised patients, because whilst it's a prodrug, it also has higher bioavailability by about 50 to 60%. And actually, in some levels, you can get it to as good as IV levels if you give it orally. It's safe and effective, meaning that a wide range of vulnerable patients can take it, and that includes neonates and pregnant women. In the UK, we had some issues with availability of IVIG for VZV, and so we started giving it to pregnant women, and now we give it to pregnant women who have been in contact with VZ all the way through pregnancy, from early stages all the way through. We don't consider it to be a risk to the fetus at all. So this means then we've got a good treatment. We should diagnose the infection faster. So, how did we used to diagnose it? So I don't know how you diagnose HSV here, but this is how I used to do it before we did molecular techniques. And it's what we call a weed. So HSV will just grow in any cell line. So you put it into cell line, it often overgrow other viruses that you're looking for if it's present in the silence. And you can see the isolation. So this is the cytopathic effect on the top 2 pictures there. And you can see that within 24 hours. So you can almost inoculate it and see it the next day. Confirmation is required, so we would do a neutralization test, or we do immunofluorescence to type it, so HSV1 or HSV2. And it does require some skill to do this. So cell culture is not something that we've maintained in the UK, and actually most of Europe now very rarely use cell culture as a frontline test, so we don't have those skills anymore to maintain this as a frontline. And so other technologies, as they take over, we are reducing that skills. It's still used routinely for drug resistance testing, so we grow the virus and then we apply the drug to it to check that there isn't any resistance. Resistance to acyclovir does occur, particularly in immunosuppressed patients, so you may need to move to second-line therapies in those groups. And then you can take cells directly from the lesions, and I just remind you that when you're taking a swab from a HSV patient or a lesion, make sure you get into the base of that swab, so decap and swab from the bottom, otherwise you're very likely to miss the virus at all. But you can do some direct staining then to look for HSV antigen within the cells. Serology is an interesting one. We do have serology available, but it is very rarely used in an acute situation, really because IgM is an unreliable marker, and it's an unreliable marker for most viruses. It's not a IgM, unless it's a really high level and it's an acute patient, and you've got good IgG levels or low IgG levels, it's not particularly useful. So we don't use it as a routine frontline test, certainly in the UK. And particularly because most people will have had an infection at some point, so it's unreliable. Is it just cross-reaction? Is it reactivation? You know, it's very difficult to define. We have HSV combined IgG, which is we use to determine immune status, so we can say yes, you've had HSV at some point in your life, and then we go down to the type-specific serology, which helps us manage pregnant women. And I'll talk about staging pregnant women in a moment, but this is where type-specific serology is used. And then obviously for seroepidemiology, it's very useful to understand what the prevalence rates of in your wider population are for HSV1 and HSV2. So molecular methods have become the gold standard, certainly in Wales and in the UK. So it's rapid, it's sensitive, and it's very specific. And that because they've been around for so long, they just get better and better. You know, the testing, the technology is just much better. The viruses are about 50% homologous genomically, so they're not exactly identical. This is why the cross-reaction between the immunity is not so good between HSV1 and HSV2. There is some, but it's not complete. The PCR kind of targets conserved regions of HSV1 and HSV2 genomes respectively, which allows you to subtype within the assay itself. It's a gold standard of choice for diagnosing HSV encephalitis. I don't know any other way in the UK that we would diagnose encephalitis except by using a molecular method. And it's also used in a frontline for management of neonates who have been either from pregnant women who have HSV or where they are sick and we want to rule out HSV. And it's increasingly being used for diagnosing genital HSV, so we're now seeing sort of higher throughput platforms now which allow us to take swabs from people who present with lesions, and we can put them through and screen them for HSV when clinical HSV is suspected. Multiple sample types can be used, so you can get swabs, vesical fluid, CSF, respiratory samples, blood, and it's basically any bodily fluid that potentially might have HSV in it. So lavage, for example, we can actually use and test using molecular methods. There's a method for everything. So let's talk about some of the specific syndromes. We'll start with the CNS infections, and I'm going to start with the mildest of the two. So this is meningitis. Now, interesting, because of where HSV2 generally resides, which is in the sacral ganglia, you normally get a meningitic picture associated with HSV2. And this is due to where the virus reactivates and where it goes to. It tends to be around the meninges rather than into the brain itself. It follows a classic aseptic meningitis picture, so you have that pleomorphic CSF and signs and symptoms of a classic viral meningitis. So, meningism, the normal sort of reactive to light. And usually you see it's more lymphocytic CSF when you're looking at the CSF under the microscope. Treatment is not usually warranted, so we very rarely treat HSV2 meningitis because it is generally self-limiting. And it's, and actually we're going to be potentially giving somebody IV acyclovir when it isn't really necessary. In a few days they will get over it. You could perhaps suggest some orals if they are having some issues. And usually, although I'm currently managing a case of Muller-Race meningitis, it can be recurrent in the same way that HSV in general can be recurrent, so can this. And this then can affect quality of life. So what can happen with Muller-Race? It's usually associated with genital herpes, and what you have is a reactivation of the genital herpes, and then you would get reactivation through the sacral ganglia, and it would go in the other direction as well, and you get a meningitic picture at exactly the same time. So the sacral ganglia reactivates and it goes in both directions. And what you end then is, you can sometimes have an overt genital herpes, but sometimes you won't. And so we generally refer to sexual health to help manage this and offer prophylaxis if necessary, because the person I'm currently managing at the moment has had 3 events in 2 years, so it really has affected their quality of life. So, referral then to manage with prophylaxis, may be helpful. Recurrence does reduce over time, thankfully, so there is some hope for these people. They're not going to end up, with this recurrent meningitis picture throughout life. It will normally sort of be, in their sort of first 5 years post-acquisition. So this is sort of HSV meningitis. So, it's something we don't necessarily manage, but it is also worth noting that if you have got this picture in somebody who's immunosuppressed, you may need to be a little bit more, active in terms of managing with treatment. Encephalitis is a different beast altogether. It's predominantly caused by HSV1, and this is because of the way it is it's basically become latent, so in the trigeminal around the face. So it goes directly into the brain, so you get replication in the brain itself rather than around the meningism. So about 90% of all cases are associated with HSV1. It is rare, thankfully, with an incidence rate of around 1 case per million of population. And so even though it's rare, you still need to rule it out when you have somebody presenting, because the problems associated with it are so great, you need to manage it aggressively. It's life-threatening and requires prompt treatment. So the mortality, even if you treat on arrival in the hospital, remains at 20 to 30%. And even if you treat really well and you get in there early, you will have long-term sequelae associated. Around 70% of people will have some form of problems associated with their HSV encephalitis, even with prompt treatment. So the sooner you get it in, you can reduce that, but bearing in mind there will have to be some counselling associated with that patient, in terms of what their life will look like going forwards. The common presenting features, so in 50% of cases, you have a fever and headache, which is a little bit, that's like any other meningitis picture. But interestingly for us is the personality changes. When with the ones that I've dealt with, personality changes have been the things that have really sort of said to us, we need to look further into this, the very early stages. So I had a HSV encephalitis case which occurred where the father came in and the family were just saying he's got a fever, but it's just a bit odd. He's just not acting as he would normally. And when we spoke to the neurologist, they'd come down to do the testing on him, and they'd asked him who the monarch of England was. And so he had said the monarch of England, and so that he had ticked that box. And the family were like, whoa, hang on a minute. That's not how he normally is. He normally gives the last 10 monarchs of England because it's his favourite subject, and he hasn't done that, And so actually for them, it was the family that highlighted that perhaps something wasn't quite right. And indeed, when they did the testing, they started him on acyclovir, he did have an HSV encephalitis. So, like I say, personality changes are a key feature, and they can be subtle. So listen to the family as they come in, because if they're not right, they're not right. And then you go on to then the confusion, the overt confusion and seizure. And then unfortunately, if you've not managed it at this point, they go into coma and can die. So diagnosis, so imaging is very useful, and the reason the imaging is useful I'll come on to, but classically the MRI imaging may show evidence of the focal edema, and that's usually in the medial region of the temporal lobe with the orbital surface of the frontal lobe, so you can sort of see very clear diagnostic MRIs associated with that. EEG is usually abnormal, initially non-specific, but you then get the leptiform discharges, which would signal then that you've got an encephalitic picture happening. The CSF profile is normal, it's usually normal. You get maybe some raised pressure, lymphocytic clearcytosis, absolutely classic, normal glucose and raised protein. But however, because of the severe edema, so as that sort of HSV begins to replicate in the brain, you might not be able to take CSF, so you will sometimes find that they're just not willing to do that. So then we have to sort of go with the imaging as the primary diagnostic tool. But occasionally that's bearing in mind that the imaging and the CSF picture can be normal, especially in early presentation. And indeed, if you take it too early, the CSF can also be negative for HSV in PCR. So it's actually the second sample. If the patient is still not responding, still not looking right, just take another CSF to confirm that diagnosis. So in the past, HSV was diagnosed on brain biopsy and histology, and this is now rarely performed in the UK, except when diagnosis is unclear, so we don't do brain biopsies. We've started doing them a little bit more now as metagenomics is coming in, because we know that about 70% of all encephalitic-like picture is never diagnosed, so it's now metagenomics is beginning to take over and starting to where we're finding it difficult to get a diagnosis, we're doing those. Intrathecal antibody measurements used to be performed. I remember performing these, and that's essentially where you compare antibody levels in serum to the levels in CSF, and then basically if you have an increased antibody level in your CSF over your serum, you knew that there was actually something happening in the brain, which would probably suggest an HSV diagnosis. We don't do this anymore. as we know that brain biopsy is fairly invasive, and although it is incredibly sensitive if you do it quickly, you get it's nearly 100%. Basically, you need a CSF to have an antibody in the first place. So by waiting for that response, you're delaying the diagnosis, and so if you're waiting for the diagnosis to treat, then you're delaying it even further, and actually really perhaps just treat. Both are now superseded by molecular methods and have been considered the gold standard for a number of years now. So both meningitis and encephalitis have a number of pathogen differentials, and it isn't always clear what the diagnosis might be at presentation, particularly if symptoms are atypical, so they're not your typical picture. And HSV doesn't always, come through the door with HSV written on it. You can see a wide range of symptoms associated with it. Using PCR for a range of potential pathogens, whilst covering the patient treatment, so start treatment sooner, for the most common is now a method deployed widely. So we do a basic HSV-1/2 enterovirus and meningo and pneumo PCR just to cover the first bases before we move on to the next round of potential causes. And for HSV, the sensitivity and specificity using PCR is greater than 95%, so it's really good now. The methods are so much better. About 5% of cases do remain PCR negative, and that's usually for two reasons. The first being that it's been collected within 24 hours, so there isn't time for the virus to be in the CSF, or after 14 days. So when they've gone down the line and said, right, now we're going to do HSV diagnosis, doesn't mean it's not HSV, it just means that they've perhaps been treated promptly and the virus is no longer present. And so what we've got now is clinical algorithms and protocols available globally which have been developed with PCR central to laboratory diagnosis. And so really, it's now moving on from CNS with what else can we use molecular technologies for HSV diagnosis. And if we look at the testing and treatment algorithm for the BIA, you can see that actually lots of algorithms exist, but actually the key points remain the same. So tests for multiple pathogens are possible. If it's HSV confirmed, you treat for 14 days in an adult with IV acyclovir, 10 milligrams per kilogram, 3 times daily. And if it's confirmed in babies under 30 days or immunosuppressed patients, you treat for 21 days. And then you repeat the DRP, and this is when you end up in that cycle, where after your treatment is finished at 14 days in an adult, you take another lumbar puncture. If it's still positive, you retreat again for another 7 days. And you keep going until the PCR is negative, because you want to make sure there is absolutely no way that virus can be continuing to replicate within that person's brain. So you only stop treatment when PCR is negative. And what we have now is when we have our cases, we do now start to have conversations around the use of oral valacyclovir, because as you know, valacyclovir, now we can get the bioavailability up to the levels of IV that potentially could then consider sending the patients home on orals with a close monitoring at home, should they get a recrudescence of their infection. So conversations can be had, but the important thing is don't stop until the PCR is completely negative. So, in summary, meningitis is mostly caused by HSV2, can be recurrent, but the course is usually mild, and generally treatment is not required. So reassurance, generally, and like I say, if it is recurrent and associated with genital herpes, referral to gum special clinics to support those patients. HSV is sporadic, but life-threatening, and requires prompt intervention with acyclovir treatment. Do not stop, do start the treatment early. And despite that, mortality remains at 20 to 30%, with long-term sequelae, at 70% plus of all cases. So this is, really key point here. The international guidelines now point to PCR testing and monitoring as gold standards, and so that's where we are in terms of HSV in the brain. So genital HSV, and we're really going to focus on genital HSV in pregnancy. As you're probably aware, if you look at all of the antenatal guidance, we don't do routine screening of HSV in pregnancy by serology or PCR. And this is normally because you can get this reactivation that occurs in the genitals, so you could get lots of false positives associated with that. And also, because HSV does reoccur throughout life despite immunity, you don't want to give them assurance that they're not going to get HSV because the immunity is, because it can happen despite immunity. So diagnosis is normally made should a woman become symptomatic at any stage in pregnancy. So she develops symptoms and then comes in for a test, and then we would confirm HSV at the time. And at the moment, PCR is the diagnostic test of choice for us in the UK. At diagnosis, we do the timing of infection in pregnancy. So we work out how far she is in her pregnancy and when that diagnosis is made and what the diagnosis is meant. So then what we do is we do an assessment then for follow-up depending on whether or not we think it's a primary infection, a first infection or a recurrent infection. Serology can play a role, but it's not widely used. So we can use it, and this is usually the type specific to see whether or not this is her first time with HSV1 or HSV2. HSV for the pregnant woman herself rarely causes adverse issues to her. So it's usually now about managing the pregnancy and the neonate. And the risk is mostly to the neonate from the infected genital secretions. And although about 5%, when we talk about congenital HSV, has been recorded, it is incredibly rare. We very rarely see HSV associated with congenital infection itself. So let's just talk about the different staging. So primary infection is a genital infection with either HSV1 or HSV2 in a fully immune susceptible woman. So this is somebody who has never had HSV before. If occurrence is in the third trimester, there is approximately 41% risk of transmission to the neonate. And what you will find then is if you take a booking blood, you will find that she's IgG negative, so this is a way we can use the serology in antenatal booking blood. So you've got a seroconversion, essentially, associated with that. A first infection, so this is where primary infection and first infection can be a little bit confusing. So it's the first episode of genital HSV2 infection in a previously HSV1 immune woman. You do sometimes see somebody who's only had HSV2 having their first of HSV1, but it's incredibly uncommon. It's generally HSV2 in a HSV1 immune woman. It's hardly to conclusively confirm as a first episode using serology or PCR for all the reasons that I've told you before, because she won't know potentially that she's ever had a first infection in the first place. But however, transmission to the neonate can happen if acquired late in pregnancy, so post 37 weeks, due to only partial protection from that maternal HSV1 antibody. And then, of course, you have the recurrent infections where you've had somebody who's got a documented genital herpes of either HSV1 or 2, and then transmission can still rarely happen as antibody is not fully protected, but the disease is more likely to be mild. So generally in this scenario, we would monitor rather than actively follow up the neonate. And these are some of our guidance that we actually use in that. This is from our antenatal Wales guidance, which I found out quite recently is used quite widely across the UK. So we've got sort of primary first episodes, so lesions within 6 weeks, is when you're going to offer caesarean section rather than managing more conservatively. So basically lesions within 6 weeks, we would offer caesarean, and that would be our preferred choice because we don't want to risk that neonate coming into contact with the lesions. If the woman does choose vaginal delivery, we don't say you have to have this because some women do want to go, through a normal vaginal delivery. We do try and avoid then the use of invasive procedures such as fetal scalp electrodes. We don't rupture the membranes, for example, and where primary episode genital herpes are present at the time of delivery and the baby is delivered vaginally, we remind the woman of the risk of that transmission, so that she, it's 41%. You're going to potentially cause your baby some problems. Lesions more than 6 weeks before expected onset of labour, we don't actually give advice, caesarean section at that time because we can treat. There's time to treat, and there's also some passive ability for the antibody to pass the membrane at 37 weeks. So post 37 weeks, you get maternal transfer of immunity. We do treat the mother. We treat her with acyclovir, 300 milligrams 3 times a day for 5 days. We obviously, because it's quite painful, we'll offer her some pain relief as well, and then consider acyclovir 3 times a day from about 36 weeks, regardless of whether her lesions have cleared up or not. And then if they've presented in labour, we will consider IVs because we just want to make sure that she's not going to have a severe outcome herself, because obviously when you're in labour you can have all sorts of issues, particularly passage back up into the genital tract. So if we look at recurrent herpes, we basically don't do very much at all really. We can offer vaginal delivery as normal. The risk from transmission to the neonate is so tiny now because there is, the woman has already got immunity, the baby will have immunity. We usually balance the risk against, the problem with having major surgery to deliver your baby versus the risk to the baby, which is actually, the risk is conversely to the caesarean rather than to the infant itself. We do try and stop doing any sort of invasive procedures such as fetal scalp because the baby can still get herpes, it just won't be as severe, so we just want to try that. There's no indication for caesarean section if there's lesions just before onset of labour, and then we can obviously suppress the HSV if there's somebody who's known HSV positive with acyclovir from about 36 weeks gestation. So some of the other sort of complications that can happen in the presence of HSV, so premature rupture of membranes and genital HSV, we normally then call MDT, so we normally have a multidisciplinary team meeting to discuss how the pregnancy should proceed when you have sort of severe issues with them. And normally it's again about conservative management versus the risk to the neonate at this time. It's always about sort of what's going to happen for the baby. And it's really the obstetrician team, the obstetrics team, who decide whether or not they should go for caesarean, whether they feel the risk is too great. And because the benefits of caesarean do remain, but it is also down to the team really who's managing the women. And then we should also consider some treatment for the mother at that time. And so if you do go for a conservative management, we give IV acyclovir to the mother at delivery. So, and then if the delivery is indicated within 6 weeks of the primary infection, we may still sort of discuss caesarean with her, particularly if there has been prolonged rupture of those membranes, because you can get the tracking back of the things. And that's despite any sort of antibody presence in the mother at all. But concurrent to HIV infection, this is where we have real issues with it. So if you've got genital HSV, suppressive acyclovir is always offered from about week 32 in a HIV positive mother. So neonatal HSV is a syndrome in its own right. Again, this is another rare occurrence, thankfully. US incidence is around 33 per 100,000 live births. Around 50% of all the cases are now caused by HSV1, so this is just to remind you the epidemiology is changing, that HSV1 is now a real big cause of neonatal infection. True, congenital HSV occurs in around 5% of cases with profound effects on the fetus, and so you could have fetal loss, you can have some quite significant issues associated with that, and then normally that's found during their sort of normal routine follow-ups during their antenatal care. Primarily acquired from the infected genital excretions during delivery, with the greatest risk in primary and first infection, as I've already mentioned, acquired within the first six weeks of delivery. And the risk is almost negligible, so we're back down to 0 to 3% if delivery by caesarean section, so this is why we recommend it. Can also be acquired from infection by contact with the neonatal period from the mother and her visitors. And it's almost always HSV1, so neonates who acquire it, usually get HSV1, and it's often overzealous parents or family kissing the baby and passing on HSV from oral fluid, essentially. If symptomatic, so if you know that somebody's got symptoms, then obviously reduce the transmission by good hand hygiene and care when handling the baby. But like I say, because of the asymptomatic shedding, you should always be so cautious around, kissing and hugging your baby that closely, if you've had HSV at all in the past. So the clinical features, so there's sort of like 3 levels of clinical features that we look for in the neonate. So the first is the SEM disease. This is a disease which only affects the skin, eyes and mucosal. And it accounts for around 45% of neonatal infections, and this occurs within the first 2 weeks of post-delivery. And it's isolated generally to the skin and mucus level, so you may see some lesions, you may see some sloughing of the skin, you may see some sort of reddening of the skin. And it can be present as just a single lesion, so you can only sometimes see like a single lesion, often around the belly button, for example, is a place I have seen it, or a small cluster of lesions. Without treatment, though, it can progress to CNS disease or multisystemic infection. This is a very vulnerable baby that we're talking about here, so you can get progression of disease if you don't treat. The longer term outlook is very good. However, what you do sometimes see with these children is that they get recurrent HSV infection from early on in life, and they get it quite often in childhood. Over time, you do see the recurrence reduce. CNS infection is the next level that we worry about, and this occurs in about 30% of neonatal HSV infections. And the onset again is within 2 to 3 weeks post-delivery, and you have the features of encephalitis, as described earlier. Common presentations: lethargy, poor feeding, seizure, and stroke. So a bit more like a, this baby's got like a meningitis encephalitis picture. Skin lesions, interestingly, may or may not be present. So you may just have the CNS without any lesions to suggest this is HSV which is causing the problem. HSV2 does have a worse outcome than HSV1, 50% mortality if untreated and 6% if treated. So even if you treat it, you still have some residual risk associated with death. Long term, there's developmental delay, epilepsy, and then recurrent CNS infections throughout life. So actually, the risk for the neonate without treatment is actually quite significant, even if it's just in the CSF. And this is possibly the worst presentation that you see. This is the disseminated infection. This occurs in about 25% of infections, and this is usually very rapid onset, so within a week of delivery. It's similar features to bacterial sepsis, so you have a septic neonate, and it would be very difficult to differentiate whether or not this is like a GBS or a bacterial infection which is causing it over as a HSV. And sometimes HSV is not even considered, particularly if the mum's not reported any issues. Vesicles, again, may or may not be present. But what you will see is the laboratory, really abnormal laboratory results, so raised LFTs, ALTs, especially coagulopathies, neutropenias, thrombocytopenia. And usually the neonatal sepsis, if you have one in the way, should include preemptive therapy with acyclovir, because you should always have this on the differential with a septic neonate. And if no response to antibiotics, and hepatitis especially is a feature in your neonate, you really should think about HSV and consider that in your diagnostic things. There's a huge mortality associated with this if it's not treated, so greater than 80%. My line manager always said, well, they will all die, if you do not treat them. She was a strong believer that this was, that nobody survived if it got to this stage. And then what you find is even when they're treated, we find that we refer them on to the ID teams, and then they're on lifelong suppression to try and keep that HSV under control, even if they do survive. So diagnosing it, so an asymptomatic baby is really difficult. So babies born to mothers with active HSV lesions, defined as being primary or first infection, if vaginal delivery. So this is if they've wanted to go down the vaginal delivery route. Obviously, if you've had a caesarean section, most of this risk is removed, and it's just a case of monitoring. So what we do is we take swabs, we take swabs from the eyes, the mouth, and the rectum. We also take CSF and EDTA blood at the same time. And we usually wait 24 hours post-delivery because we don't want to have contamination of the neonate from the genital lesion, from the genital secretions as they pass through. We also start acyclovir at birth. So they come out, then they're on acyclovir, we wait 24 hours, and then we swab and take all the samples that we need. Babies born to mothers with recurrent infection are just generally monitored, so we don't do all of this at the top, we just keep an eye on them. Some people may swab at this point, they may want to have that extra reassurance, but basically what we tell parents is that we have a low threshold for testing and treatment. So even if they go home, we say that if they're even slightly off or a bit of, whatever, bring them straight back because we need to consider that they have been infected. And in the same way, with all of our other things, HSV PCR is the method of choice. And the sensitivity and specificity in an asymptomatic baby post-delivery who has actually acquired HSV infection is around 95%, so it's really good. Like I say, technology is really good for this. So diagnosis of HSV in a symptomatic baby just starts acyclovir. And then sample us for the asymptomatic baby, delivered to a mother with active lesions, and then sent for HSV PCR. So the same would be for, these are parents who've gone home and then the baby's not well, or you suddenly think, well, this baby doesn't look right, we're worried about HSV. This is what we would do in that scenario. So if all PCR samples at that point in your asymptomatic baby are collected are HSV negative, we stop all the preemptive treatment. We don't do any more treatment at that point, and we go back to monitoring, because obviously you could have a delayed response. For the skin and mucosal infections, if the PCR swabs are positive, we do 14 days of acyclovir, and then we just stop at that point if there are no CNS signs. There's no further action required. For CNS and disseminated infection, we do, this is where the CSF and or EDTA blood that we've collected at the same time are positive. We do 21 days of acyclovir and repeat that sample and wait for the negative. So we go into that same loop that we do for the encephalitis picture. And we also then consider suppressive therapy when that treatment's completed. So, in summary, neonatal HSV, thankfully, is rare, but it has considerable mortality. Like I said, my boss always believed they would have died if left untreated. Maternal immunity does play a role in neonatal disease, and so is used to guide management. So you do need to understand something about the maternal history when you're managing the baby. PCR is the fastest way to diagnose an acute infection. There are 3 types of neonatal infection described. So the one that just involves the skin, the eyes, and the mucosal layer. There's one that just affects the CNS, and then there's the disseminated, really awful, sort of septic neonate type picture. Prompt treatment with acyclovir reduces the mortality rate and can limit long-term morbidity. And like I say, the mortality rate can drop to just 6%. So it's not gone completely, but it is quite a significant reduction. It's a similar role to HSV to a neonatal disease itself, so the disease presentation, you will still get it, albeit with lower severity, so you might not see that same extensive effect that you would see with the disseminated infection with HSV1, but it does play a role. So in summary, this is my final slide on this, the diagnosis and management of HSV has been influenced by the availability of safe treatment, and this often is the way with most molecular tests. If you've got a good treatment, you want to diagnose it, and molecular methods seem to offer that much better. They've largely replaced, in fact, our classical laboratory techniques. Certainly in the UK, we don't use any classical, HSV diagnostics tools. And even in relatively mild genital infections, we're now seeing that switch over to molecular methods to screen, mass people or test lots of people for it. Severe HSV infections benefit from the rapid result afforded by readily available, and we've moved more and more to commercial tests. When I first started my journey on HSV diagnosis, it was all in-house. We were designing the tests ourselves. We're now, using far more commercial tests. And most guidance now, if you read most guidance globally, will point to PCR as the test of choice when diagnosing acute HSV infection. So it's not like we're doing anything new and amazing. It is actually out there in the literature that it is a better way, particularly for those severe presentations. And these I've put some references and further reading there, so for various articles on HSV, and also our own sort of guidance as well from the Royal College of Gynecologists, so please look those up. And I have any questions here. So this is one of those giant herpes, giant toys, which is herpes, and it reminded me so much of daffodils. And because today is St David's Day, I thought I'd finish on this. Thank you.
Thank you, Dr. Catherine, for this presentation. For questions?
Thank you, Dr. Moore, for a very enlightening talk. My question to you is very straightforward. What is your experience with the use of famciclovir versus acyclovir in the treatment of herpes infections?
Famciclovir.
Famciclovir.
I've never used famciclovir. We've used valacyclovir or acyclovir. Famciclovir hasn't been used as far as...
Because of the cost in NHS?
I suppose it comes down to benefit of use, because acyclovir is so good. The mode of action is pretty much the same, and valacyclovir is becoming more widely used. So valacyclovir has better bioavailability. So I suspect it's more to do with that and whether or not the NHS will pay for it, I suppose, on the basis of the fact we already have a good effective drug. And I suppose the mode of action being the same, so even the resistance mechanisms would be the same. So it's not like we would get anything over the fact that resistance would be improved if you changed drugs. So I suspect it's probably lots of things have weighed out, but having acyclovir and valacyclovir available to us probably weighs against it currently being used widely. That's not to say it wouldn't be used. We will have anything in our armoury, but I suspect the mechanistic way wouldn't put it above valacyclovir.
Thanks very much.
Is there any other?
Thank you, Doctor, for the wonderful presentation. My question to you about the infected mothers. Is there any kind of passive immunity that will transmit to the baby during pregnancy or after delivery during breastfeeding or something like that, that could give protection to the baby against HSV?
You will have maternal transfer after 37 weeks. So if you're infected pre-36 weeks, then there will be some level of maternal transfer of passive immunity, but it's not fully protective. So we still would want to monitor a baby even at that point. In terms of giving passive antibodies to the baby, that has been tried. It's not particularly used. We generally just go for acyclovir. So in terms of, so there will be maternal transfer, but again, it depends. If it's HSV1 and a HSV2 infection, you won't get full protection. If it's HSV2 and a HSV1 protection, you might get a bit more protection, but then it comes down to the type that's being transferred as well, because it's neither are complete, and it has to happen before 36 weeks. So 36 weeks would be your cut-off, really. If you've acquired it after that, there is no passive transfer at all.
Thank you. Thank you.
Is there any other questions for Dr. Catherine before we go to our coffee break?
Oh, I've got to put that on.
All right, then we'll go now for a brief coffee break for 15 minutes, and we'll be back for the second part of the presentation. Thank you.
So this is a complete change in tack in terms of what I was talking about. Well, this is more about my other job that I do for Public Health Wales, as my role in developing and implementing molecular testing for the service in Wales. And I'm focusing on the GI tract, which is what I've been asked to focus on. So I'll talk about sort of the implementation that we did for that, but also I'll use it as an opportunity to talk about how you implement syndromic testing in a laboratory setting. So not just about the GI, but in general, because the principles for what I'm describing now are the same for everything. So I'll have some acknowledgements because most of this work isn't mine. So Michael Perry, who works for our C. diff reference laboratory in Cardiff, he's really been driving the force behind GI testing in particular in Wales. And then the other two, Laura and Sophie, have been involved in some work that I've been undertaking, doing some validation work on GI testing platforms, newer ones compared to what we implemented in 2016. So presentation outline, I'm going to talk about what multiplex and syndromic testing is. The challenges, some of the challenges that you'll find when introducing syndromic testing in particular over the single test PCRs. What we did in Wales, the sort of process that we did going forwards, and also then the future. So multiplex testing is a means by which a single clinical syndrome is investigated simultaneously, so exactly the same time, for multiple likely causes using a diagnostic tool or a multitude of diagnostic tools. These are more often laboratory based, so you won't generally do these in a clinical setting. So you have a patient, for example, who presents with diarrhea and vomiting, and you know that there are multiple causes associated with that. Well, there are a range of methods that you might deploy to actually diagnose the actual cause on this. And so it can be performed by different methods. So for infection, so bearing in mind that a clinical syndrome can be non-infectious as well, so the same process is true. So multiple sample types can be collected using a combination of culture, serology, and or molecular. So molecular might not be your frontline test, you might be using culture, bacterial culture, you might be using serology at the same time. If you're using a purely molecular platform, however, you can do this from a single sample. So you don't need to take multiple samples, you can just use one sample to get the same answer. And you have a wealth of choice out there, so there's lots of things to choose from. In terms of molecular testing, if you were to go down that path, And what I've roughly divided them into is what we call classical molecular and sample to answer. So classical molecular are your big beasts. So these are the ones where you would bring your samples in, you would do an extraction to get your nucleic acid. And I like to say to people that it doesn't matter whether it's bacterial, viral or fungal, everything ultimately is nucleic acid. You just need to skin it to get to it. So that's the point of the extraction process that you have there. And then you would do a separate amplification, and sometimes even from that you would do a separate detection step. So it could be 1 step, 2 step, or even 3 step. This is the way a lot of systems are going now. So you have these sample to answer systems. So you put your sample into a cartridge or into a cassette. You pop it into the machine, and 15 to 2 hours later, an answer comes out at the end with what the nucleic acid is in that sample, and possibly the likely cause of the infection that you're looking for. So these are classical molecular and sample to answer. And this is the way that a lot of companies are heading in direction, because they offer easy access and less skill in terms of actually doing the test. So when we talk about syndromic testing for molecular testing, we're talking about panels of tests. And so they're increasingly complex. So originally you could do sort of like 2 pathogen targets in a single well to 20 and above in one test. And they cover all ranges of different sort of clinical syndromes, from sexual health, respiratory, which is my sort of area that I generally work in, gastrointestinal infections, and then meningitis and encephalitis. So I work between respiratory and meningitis as 2 areas that I'm particularly interested in. And Michael works on sexual health and GI. So we've kind of worked together on a lot of these different panels. The sample to answer platforms are really seductive to people because they are so quick and so easy to use. And these are the ones that you often see in GPs and pharmacies. So you take your sample, pop it in, and you get the answer. And if they're really quick, so 15 minutes to up to 60 minutes, so you can do it whilst the patient is next to you. And this is what's increasingly happening. We're now calling these point of impact testing, so you can bring them into your primary care centres, into your emergency units, and into pharmacies. And in Wales, we've just done a recent pilot study in our pharmacy where we had people who presented with a sore throat. They would take a swab, and they would find out whether or not they needed antibiotics, whether it was a bacterial infection or a viral infection. And similarly, we're doing a similar trial in our primary care, so with our GPs, looking at CRP, so to see whether or not somebody has a viral or bacterial. So they're actually taking them out of the laboratories, which for a laboratory person probably isn't the way we really should be going, in my mind, but hey. So, the challenges, and there are lots, and this is actually what puts off a lot of people when we're actually talking about taking them closer to the patient, because as soon as you start talking about quality and managing and where the results go, it really puts them off, So the first thing we have to consider then in all of this is the cost, because you're often talking, going from a simple sort of plate test that you might do for a bacterial target to like for pennies up to sort of pounds and dollars, many dollars in terms of the amount of cost that you're using. You have to do lots of validation and verification. So by validation, you're obviously validating the system for use in your clinical setting, and for verifying it, you're basically saying it does what it says on the tin in terms of the infections that you're interested in. And these are not simple processes. When you're doing a full validation, a full verification ready for service use, it can take a lot of work and a lot of reagents to actually get to the answers you're doing. Then you need to do further quality assurance. This is with external quality assurance panels and also IQA. So these were mentioned earlier. I saw so QCMD, for example, is a molecular quality EQA scheme which we follow quite rigorously in the UK. And IQA is something that we develop internally to make sure that our test continues to detect what we say it does. Then you have to be proficient in doing it, so the system has to be proficient in doing the diagnosis, but the people who are doing the test also need to be proficient. And this is where we find some of the issues when we come to doing point of impact testing. So when we say to our clinicians, well, okay, we need to make sure you're proficient, so this means that we will send you a panel every 6 months, you run it, we make sure you get the right answers, and we record all those answers. It really does put them off, because their idea is that they get the system in, it's so easy to use, they tell everybody how to use it, but there's no actual monitoring on how proficient those people are. So they have all of their nurses using it, they have their admin staff using it, but they actually haven't monitored who's been trained by who and by what method. Control material is actually another issue that you have. So if you, in your panel of many, have a target on there which is actually really rare, so you don't have, it's not a common find. So for example, on one of the respiratory panels that we have, there's MERS coronavirus. Well, if you were to do the quality control material for MERS coronavirus in the UK, where we have no MERS coronavirus, it's really hard to get the control material. So we end up having to fabricate material to allow us to control that particular assay in a good way. And then you have to collate all the results as well and understand those results, and so LIMS, so if your laboratory system has a good network, you need to make sure the system goes into your LIMS and that they're recorded appropriately and that the results are recorded then in the patient's notes. So it all adds up in terms of what you're doing. And then you have to, as clinicians, wonder about how you manage people who have 2 infections or 3 infections or 4 infections. And this is a real issue for some of our clinicians who work in paediatrics, because if you're under 5, you get lots and lots of infections, and these multiple infections can be detected using these syndromic panels. And so you have lots of things to consider there before you even get the system through the door. So in the UK, we have to have all of our laboratories underneath a clinical governance framework. We have to follow UCAS accreditation, so every 2 to 3 years we get accredited by systems which come in to make sure that all of our systems are doing what they're saying, that we're all proficient, that we've got the right controls, and the results are doing exactly what they should be doing. And it's not easy to achieve. So, let's go back. So we wanted to introduce multiplex testing, not just for GI pathogens. We also had on our list respiratory, and we also had on our list CNS infections. And so let's go back to GI. So why did we want GI on there? Because, ultimately, if you look at it in the big picture, it is the 8th leading cause of death, especially in young children, the elderly, and the immunosuppressed globally. So the wider picture says GI is definitely the way you should go. You should be diagnosing these molecular testing ways. And interestingly, the first thing that really comes to my mind, and I'm a virologist, not a bacteriologist, most episodes, when I speak to my bacteriology colleagues, they say, well, it's self-limiting. You get diarrhea, you eat something, you get diarrhea, and then it goes away, And most in the UK, most of the common pathogens that we detect are norovirus and Campylobacter. We like our barbecues in the UK, we just don't like cooking our chicken. We just like, vaguely raw chicken. And then we also have the antibiotic-induced diarrhea, which is a real headache for us. So one of the sort of healthcare-associated infections, which is Clostridioides difficile. I'm just remembering to rename it, because my colleague would be really annoyed if I didn't. So we have these 2 areas here where in my mind, as a virologist coming into this, these are probably the 3 infections we want right up there. And I was told, no, it's bigger than that. The problem is bigger than that, and we really need to think about this. Because rapid diagnosis for these infections allows for appropriate antibiotic prescribing. So AMR is a huge problem in the world. If you know that your diarrhea, even if it's really bad, is Campylobacter, you're not going to treat that. But if you have something that you might treat, or something which is travelling related, then you might need to treat that and manage that better. You can identify clusters more quickly, and then identify outbreaks. And then you can support infection control, and that's certainly the case with C. diff. So we use it to manage our C. diff cases in the hospital and to help support our infection control. However, we do need to balance that cost, because that cost always comes in, particularly in the NHS, where everything is free at the point of impact. So people come to our services, they don't pay for us, so there's no insurance things. So we do have to balance that. So we don't take it into our hearts that we just because you can do a test, you must do the test. You have to have a good reason for doing it. So part of my job, when I do my job in this area, is to actually write the business case and to give the justification for why we need to move over to this. And actually GI was probably one of the hardest ones we had, because that line, most episodes of diarrheal infection are self-limiting. So why would you put the cost in for something which isn't that significant, or seen as that significant? So we're going to go back to Wales, and we're going to go back to 2016. So this is when we started this large project and looking at how we changed the service in Wales. And what we wanted to do was implement and support a national molecular testing in a syndromic manner. We knew syndromic testing was the future. How do we implement that effectively in Wales? And so we did a review. So a few of us went around the UK and into Europe and looked at how laboratory services were evolving and bringing molecular diagnostics in as a central feature for their testing strategies. And in 2016, so I don't know if I can get the pointer to work here. Can you see that? Okay, so I'm based here in Cardiff and Vale, but you can see with lots and lots of, all of the lines here are our health boards. Public Health Wales has 5 laboratories across the whole of Wales, and we look after all of those laboratories, so Public Health Wales. And then there are 3 which sit outside of Public Health Wales, so these are the NHS labs. But we all work together under the same common SOPs. So all of our labs are standardised, all of our reporting is standardised, and all of our clinical teams are standardised. And so I can log on to my system in Cardiff and I can review all of the results in Betsy Caswalder, which is our North Wales Heath. We're completely linked. So we weren't just talking about changing one lab, we were talking about changing the entire network. And this was a phenomenal piece of work. We, at that time, tested 83,000 faecal samples a year. So most of those were actually coming in from our primary care practices. So we were doing mostly C. diff, a little bit of chronic diarrhoea in our hospitals, but the vast majority was coming in from GPs. 2017, we got funding approved to implement GI molecular testing in Wales. We needed to understand how that might look going forwards and what targets we were going to use to implement. So, this was our case for introduction. It was actually quite a long road, although it was a very short road. We had to do this quite quickly because the money was going to be lost to us otherwise. And we wrote this document here called Molecular Diagnostic Service in Wales, and what it did was it gave a vision about what we wanted our services to look like. So we went from where we were now, what our services look like now, what our staffing looked like, and where we would take that forwards to actually bring a better response to our service users and also to the patients, so a better patient experience. We're moving far more towards patient-centric management of cases in Wales, and diagnostics being central to that. So this is a very busy chart, but this essentially shows our GI bit. So I have pages for this for CNS, we also have pages for this for respiratory as well, and they look exactly the same. And what it looks like is basically what we do now, what our current system looks like. So we've got at the top here, so Campylobacter, non-typhoid Salmonella, Salmonella typhi, Paratyphi, Shigella, E. coli, and VTEC. And in this box here, it just says routine bacteriology culture, because that's what we did for those particular targets in 2017. Coming down, we've got C. diff, when we do GDH, EIA, followed by toxin confirmation, and we used a rapid test device. We had one of those point-of-care type tests to do our GDH testing. And then we did some cryptosporidium testing. We're quite lucky in Wales. We have 3 reference laboratories for the UK. One is the cryptosporidium reference unit, which also looks after Giardia, and we also have the C. diff reference unit as well, and the anaerobe reference unit. So we've got those 2 systems already in place. And then we've got specialist culture and microscopy here, which would include your ovaries, cysts and parasites, which would go for your routine microscopy. Very skilled, and at that point we had one laboratory in Wales which were really super skilled, and that laboratory was in Aberystwyth, which is, if you remember the map of Wales, which sort of sits in the middle of Wales. You know, it was incredibly good. So they basically were probably the top in terms of doing that type of work. Then we come down to sort of the Vibrio species, Staph aureus, Bacillus cereus, where we do routine culture of cases from food poisoning or specific organisms from immunocompromised. So they sort of kind of had this kind of unwieldy pattern here. And then Yersinia species at the bottom there, where we did reactive arthritis, appendicitis, terminal ileitis, etc. We did some testing there for them, but it was all very bitty and, you know, really quite sort of disjointed in terms of what we did. And bearing in mind, this was all being done in 5 different laboratories, quite, you know, very difficult to standardise the process. This box here is, to my shame, is viruses. because it was really poor what we did for viruses. And I'm not saying that we improved any better, to be completely honest with you. So norovirus was the only virus that we were doing any molecular testing for at the time, and that was a test that I introduced like years and years before. We weren't doing any testing at all for rotavirus. That was all done on rapid testing and an ELISA. We did no sapovirus, no astrovirus. We had to refer that to a lab outside of Wales because there was no testing for that at all. And adenovirus was very ad hoc. Although I had a PCR, it wasn't really validated. So I want to talk about validation and verification for stool samples for all adenovirus types. So it was all very, very bitty. So as part of this process, we did some Gantt charts. So this is a Gantt chart of what our process looks like in 2016 for bacterial culture and GI testing in general. And so at the top bar here, you've got microscopy culture and sensitivity testing, and then down here you've got the C. diff stuff, which obviously was Michael's thing at the time. And basically along the top there, it's got time in minutes, and then we just sort of give up and then go to days. So to get a result from following all of your things, and we counted sample processing all the way down to reading and reporting of culture plates, and then all the way down to microscopy. We did have mouldy tough at the time, so we were starting to use mouldy, but it was not really part of our routine time. But you can see that actually when you come down to it, it took about 3 days to get a result out at the end of the day and to confirm a positive. Negatives possibly a little bit earlier, but actually the time scale was the same. And then for C. diff, we were sort of into although you could get a result out in the same day, it was still quite long-winded. So this is where we were going from. Very ad hoc testing, lots of different processes, and 3 days to get a result. So, like I say, very few samples were tested using a molecular platform at all, norovirus being the exception. The time to result we measured in days, and evaluations had been starting to be undertaken, so we started to get some of the syndromic panels in to have a look at. And we started sort of using them in anger for 2 events, essentially. So we used the Luminex GPP, the very first iteration of the GPP, to support the diagnostics during the 2012 London Olympic Games. So that's how long ago we started looking down this path. And the reason we'd done it was because some of the teams were staying in Wales as their base. They were training in Wales. And if they got a GI outbreak, we needed to know what it was causing it and to basically allow them to participate in the games, not cause problems for them. And then we used it again during the NATO conference, which was held in Newport in 2014. So this is the only time we'd really used molecular in anger in any syndromic testing for GI testing at all. But already we were seeing that improvement in cases, so it gave us a little bit of impetus and a little bit of a foothold to begin to say, well, actually, we need to look at this in more detail. And so if you look at the comparison rates, so this is just 1,400 samples that we had run through those 2 events. You can see sort of the current events, the current methods, traditional unwieldy way of bacteria are in blue. Parasites, so it goes bacteria, parasites, viruses. We'd only ever done molecular, so that's all the norovirus, and C. difficile at the end. And you can see already we're beginning to see that increase in rates. So we're already saying, well, okay, this is great. We can improve diagnostics and we can do it faster using molecular methods. And we can show improvement to time to results. So these are 2 different setups here. So on this side here, we've got time in minutes, no days, thankfully. It goes from sample processing, extraction, booking into limbs, we'd even included that in there, PCR preparation and results reporting. We've also included analyzer shutdown to really give a real breakdown of what it looks like to actually change over. And even then, with all of that taken into place, using this particular system, which was the original Luminex GPP, which had a hybridization step, we could still do it within a day. And on this side here, we've got another system which was also being set up, which was a little bit easier. You did the sample extraction and set up together and extraction, and then the PCR was automatic. And so you can see there that the reduction again was still really good. So we've already shown that workflow could be improved. So these are the benefits, right? So this is how we summarised them. So we went from a turnaround time from 24 to 72 hours for a result. And we reckoned that we could get a turnaround time of within 3 hours to a day, depending on what confirmation you were doing. The most important bit for us was about the whole time equivalence. The next line is also one of the ones that is really difficult to get across to your service users. It's about your scientific staff, your whole time equivalent scientific staff. So for that long-winded process that we were doing, we were using 11.8 whole-time equivalent healthcare scientists to perform that work, along with 9.2 whole-time equivalents of your supportive staff as well. So there's a lot of support, a lot of staff involved in getting that service. If you just simplified it, it meant that we could go down to 4 whole-time equivalent scientists delivering the same service, but in a faster turnaround, with a simpler flow, and only 3. So 7 staff compared to 21 staff. So, you're reducing it, by an enormous number. But it didn't mean we were losing those staff, which is the one thing we're using. It just means we could redeploy them into areas where we needed them more. Because at the moment we were also very short-staffed for scientific staff. So you don't want to lose them, you just want to put them into doing work, which is actually used. 10% of our GI samples were positive at the time. Using a molecular method, we already knew that we could improve that by 30%. And then we had poor ascertainment of our key pathogens. So those key pathogens associated with healthcare-associated infections, we only had a 10% positivity rate. So just looking at those in our past data, we already knew that we could increase that by up to 40%. So it was all really, really good. The key thing here, though, was actually improving people's ability to do molecular testing. Molecular testing isn't just a case of sample in, sample out. There is a process that needs to be followed to maintain all that insurance, but also to reduce the risk of contamination and making sure that the results that come out at the end of the test are usable and interpretable, and ability to manage the system as they go forward. And we were going from staff who were very used to spreading plates to suddenly having to pipette small volumes, and to manage, testing using a molecular platform. So it meant then that we could take our less than 20% workforce who had any experience of molecular testing and transform that into greater than 80% of our workforce being able to do a molecular test using either of those types of platforms, be it an extraction amplification platform versus a point-of-care test. They could do all of that. So we would transform our workflows. And the other thing that was really quite important to us, in Wales we have a huge sort of environmental rally from the government where we need to have our recycle rates up. We put in as well that, doing that sort of long-winded sort of process for GI infections, that we were producing about 15 tonnes of hazardous waste every year, which needed to be disposed of by the health boards. And we could reduce that down to 1 to 2 tonnes, so quite a significant drop. It's not completely there yet. We'd like to see that reduced further, but it's still, for us in Wales, that was a real big sell for us. So what are the downsides are there, though? So, you have to balance up the good with the bad. And the thing is that, classical microbiology, we still use it. That's not going to go away. And as you de-skill the staff, how would you replace them, particularly as the expertise moves on, in things? Detection of dead bacteria was a real concern for some of our clinicians, and certainly some of our health protection team colleagues as well. How do they know that detection is true? How do you know that it's not just hanging around? So that was a real issue for us. How do you assess the impact on the wider services, including health protection? So when you suddenly have an increase in detection rate of a certain infection, you're going to suddenly implement, action plans for your health protection teams who need to manage that outbreak. I remember when we first introduced chlamydia molecular testing, our chlamydia rates went through the roof, and we went to a meeting and our health protection teams had published a poster saying that we had outbreaks of chlamydia, which we hadn't, we just had better case ascertainment. So there is, we need to engage quite early. How do you standardise that reporting? Like I say, the Welsh network is one, we work as one, so you need to make sure that what reports from the north occur, are the same as what's reflected in the south, because we're using the same reporting system, so it needed to be standardised. And then how do you implement the technology into a group of staff that has very little molecular laboratory experience, particularly with things like faecal samples where you will have high levels of pathogens, so contamination of the environment is a very real threat, so you need to make sure that they are properly trained to manage that. So the first thing we did was we reassured our staff by saying that we were going to have confirmation pathway for some of our key pathogens. And this is actually taken from our current standardised SOP about what we do with positive patients. So, and you can see that highlighted in there, we've got Campylobacter culture to follow, Salmonella culture to follow, Shigella culture to follow, and E. coli 0157 culture to follow. We had a really nasty outbreak of E. coli 0157 in sort of 2013, so it's really stuck in the Welsh memory that we really need to make sure that we're not letting those go. So you can see that we do have culture still in play. You know, it still plays a major role in terms of what we confirm. And it also then means that if we've isolated it, then it must be a true infection. You know, and so that means then that you know, we can give our health protection teams a bit more reassurance that they're not managing something which is dead. You know, so that's quite useful. And this is the has it grown pathway. So this is one of our confirmations. And it literally says, the line along the top, Campylobacter positive, has it grown? You know, we ask the question, and if the answer is no, we send it out with a not isolated comment. We send it out saying we don't think this is real. We've detected it by DNA, but it's not, you know, likely to be real. And then obviously if it's grown, we go down the mouldy pathway. We do agglutinations, we do confirmation, we do, you know, all of the right things. And then VTECs at the bottom here, at the back here, obviously because we're worried about those, they go then to the microbiology queue. So there's automated, once we've standardised a lot of our authorisation, they can automatically be sent out as well. So we're not having to go to the medical queues for absolutely everything. So it has worked really well in that way. So we have to select the correct panel though, because if you look at the market nowadays, there are a lot of panels out there, and some will only do very few targets and some will do like hundreds of targets. So you need to get the best value for money from that test, but also in a way that you can interpret it and not confuse the situation. So for us, we used it as an opportunity to consolidate bacteriology and parasitology testing and to introduce to that cohort of staff molecular testing, because they'd never done it before. We went through a formal tender process once we decided that we were going to go down this path, and we based our key targets, this is, like I say, back in 2017, based on the UK standard microbiology investigation guidelines. So it included Campylobacter, Salmonella, Shigella, E. coli 0157 and or S-Tax12, C. diff, Cryptosporidium giardia, and we put norovirus in because the bacteriologists were leading on this, and norovirus was the token virus that they added. So I didn't get all my viruses in, but I at least got that one. And we introduced it in 2018, so it wasn't, so like I say, though the road was short, it was actually, we didn't actually get it introduced in 2018. And what happened was a really interesting thing, because Welsh Government filled the money difference. So our health boards were paying, one of the cost issues, for all of that long and windy path, a single sample might have only cost about £30. And we were now going to, take that cost up for a positive to maybe £50, £60, per sample. So you're increasing that cost. So what Welsh Government did was they backfilled, so they paid the difference. So our health boards only paid for the cost of the test that they would have done if they'd requested it using their traditional methods. And what that then allowed us to do was to look at the transformation of the service and actually review it in more detail, so that we could then feed back when we were coming next to our next tender process to say whether or not we needed to continue down this pathway, what benefits it offered, and also, how it had impacted on our service users. And this, particularly for GI infections, like I say, was always going to be a hard sell because most are self-limiting. It's particularly how we managed outbreaks in Wales. So we did a service review, and this was only published in May 2022, and it was published in Journal of Medical Microbiology. I've got the little DOI there if you wanted to have a look at it. It didn't really pick up much traction, so if you look at the citation index, I don't think people realise what we did, because it is multi-centre, because we've got all of our labs in Wales running it, and it's a lot of samples. So we did a retrospective analysis of 34 months of data from the pre-implementation phase to 2 years post-implementation across the entire network. And we reviewed, well I didn't review, but Lucy and Michael reviewed the results of 961,573 individual reports, followed up those reports, had a look at what the results meant, and to see whether or not the impact was really, reflective of the effort that we put in and the cost of actually bringing it. And so basically what we did was we followed NAT introduction. Bacterial culture was performed, as I said, for secondary test to provide further information for those NAT positive samples for epidemiological purpose. What was circulating? What did it look like? What was the AMR profile? We still needed to do all of that. And then the primary detection rates and overall bacterial culture rates were then calculated depending on whether the sample had come from a hospital, which was our stage 1, or from the GP practice, which was our stage 2. And these results were actually quite interesting. So what we showed was that in stage 1, that in hospitals, our detection rate did go up significantly for all of the pathogens that we were looking for. However, what we found was that actually for Campylobacter, when you tried culturing it, you were culturing less. So although you were detecting it in hospitals, it wasn't necessarily reflecting what the patient was coming in with. So the culture went down a bit. And that, was a bit alarming because you think, well, gosh, we're doing all this testing for no reason. But actually, when you look at our healthcare-acquired infections, we were actually detecting those as well because everything went up. So it was all sort of normalising ever. However, the interesting thing was really our GP practice. So if you recall, when I said right at the start, most of our samples for GI testing in Wales come from GP practices. And actually, most of the positives cultured. So what they were coming in with was actually what we were detecting in the community. So we weren't sending our environmental health officers on wild goose chases because the bacteria that was being detected was viable and was actually causing the acute infection that they're coming in with. And so what we would say was that the implementation of NAT significantly increased the primary detection rate of all target enteric pathogens in Wales. And then we managed to say that, that we weren't losing any information by just going down a molecular platform because we were, keeping some of the direct culture. And obviously with molecular testing changing, we're also doing far more next-generation sequencing. So all of our Campylobacters get next-generation sequencing, all of our Shigellas get next-generation sequencing to keep on top of what the epidemiology and the AMR rates look like. So the technology is moving along with the actual methods themselves. So the future, for GI in particular, we've just re-tendered the service and we've expanded the key targets even further. So we've now included all of the viruses on my insistence. We want to know what's happening with rotavirus, as a vaccine preventable disease. We've trained additional staff, and by doing that, it really helped in the pandemic. So we had this converse problem where suddenly we had lots of staff who were able to do all the molecular testing. So when everybody needed to have a SARS test, we just put SARS platforms into all of the labs in Wales, and all of them could deliver SARS testing. So our capacity was increased phenomenally due to the fact that we have already had 80% of our staff trained in molecular techniques. And we also then were able to expand our laboratory capacity. So one of the things that's come out from the pandemic is that not only have our main laboratory network increased in terms of their molecular testing, we also deployed a series of hot labs because molecular technology has moved on so much and we can do much more point of impact testing. We've now got hot labs in each of the hospital sites in Wales, which they didn't previously have microbiology as we began to centralise and contract the service, which used point of impact testing or rapid testing, including some of the syndromic testing like the biofires and the Kefids in the system. So actually we've moved that out, and certainly the norovirus and C. diff is very popular now, so we've now got that running routinely in all of our hospitals settings so that we can have sort of direct feed from our infection prevention control teams. And so in summary, syndromic testing in general is becoming routine in most diagnostic laboratories in the UK, so we seem to be going down that way. When implementing this testing though, you should consider the target population. Is it GPs? Is it hospitals? Are your cohort largely immunocompromised because your targets may be different? You may want to expand your targets for immunocompromised patients. Are they children? What kind of targets are you looking for? The staff delivering the tests, if you're new to this, may require further training, and really consider how you're going to deliver that training, because you don't want contamination issues. You want to be able to trust the results that come out of it. And what we found is certainly from people working in classical bacteriology or laboratories that only dealt with serology, they weren't entirely familiar with molecular pathways and separating rooms, etc., for your clean reagents, your dirty reagents, and single flows, for example. So getting all of that into training is really important. So your type of test implemented as well, you should consider the location and your time to result. How quickly do you want it? So it's no good putting in a big platform into your ED because you can't do 3-hour tests there. You really need to do something which is less than an hour. What I've called it is whether you want black box or separate extraction and amplification stages. So this is what we do when we're reviewing, when we're putting new platforms. And the target selection should be based on your local need and not just because you can. So it's no good putting in something for an arriving traveller into an area where you're not going to be doing traveller-related diarrhoea, for example. Or you may want to do more in your arboviruses in an area where you get lots of travellers coming into an area for it. And then also you must consider that clinical interpretation of these results can be quite challenging, particularly with 1 or 2 targets flagging positive. But however, the network-wide implementation, by going the whole network rather than just single labs, really did help us in terms of the staff rewards. They felt that we were investing in them and taking them forward with the technology, we weren't leaving them behind. The patients got a better turnaround, they weren't waiting for results. And it improved the time to result and staff skill level in general in molecular diagnostics. So we now have a workforce in Wales is probably, for bacteriologists definitely, really have a good understanding and feel for how molecular methods work. So I'm really pleased with it. I mean, GI was like the big sell, but because it was very bacteriology focused, it did bring that staff group in, whereas if we'd gone for CNS and respiratory, we could have just carried on with the virology side of things, whereas, with this platform, we move out. So it means then that as we implement new things, so sexual health and CNS, we can already put it out into the wider network because they already have the skills ready to do that. And so, diolch yn fawr, which means thank you very much in Welsh, and I'm happy to take any questions. Thank you.
Thank you, Dr. Catherine. Is there any questions?
Hi, Doctor. It was excellent talk. Just one question. How do you claim it from the institutions? Like we are private hospitals here. You are funded by government, but here we are private. How do we claim this multiplex with a single CPT code? I mean, I saw the biofire there. You had also shown the biofire. The biofire has, I think, 20 pathogens.
That's right. Yeah.
So, do we have any single CPT code for that?
I don't know about coding. I wouldn't be able to answer those questions to your country. What we have found with biofire, so we implemented biofire for SARS, weirdly enough, and we found other pathogens which weren't SARS, So, yeah, I mean, we don't have costs per target. It's the cost per test, if you see what I mean. I don't know how you would claim that back locally. I would have to defer to the colleagues in the audience who know about, costing for you. I mean, the NHS is slightly different, yeah.
Thank you. Thank you again for your informative presentation. My question is, do you use the molecular panels to follow up the patients, or you save it only for the first time diagnosis?
No, we follow them up using molecular techniques as well. Yeah, so the molecular panels can
For
be
how
used.
long?
Well, we don't do clearance testing for GI. It would only be in people who are immunocompromised who might do some follow-up testing. Generally, it's treat and resolve, or not treat, as it were, manage, until they're better, and then it's usually following the 48-hour rule, for symptomatic management in terms of infection control. We don't really test and test and test.
So, do you keep testing the patient till you get a negative result?
No. You get the positive, you get the diagnosis, particularly if it's confirmed by culture or by other methods. We just follow the rule, just make sure that they become asymptomatic at some point, monitor them that way. It's more about infection control for us. Because like I said, most of these infections, for us in the UK, are mostly self-limiting. It's only in immunocompromised where we may want to do further follow-up testing with them. And sometimes we will deploy the test again. So for norovirus, for example, we can follow them up for norovirus.
Thank you.
Is there any other questions to Dr. Catherine?
Hi doctor, what about the multiple pathogens if you detect, you would go for a quantification like the copies if you have multiple pathogens, will it report all the multiple pathogens or you will go according to the CT values or?
No, we report them all. We report them all. See, most of the black box technologies don't give CT values, so you just get a yes/no answer. What it comes down to then is clinical symptoms and onset. So it is, they are the most challenging things to actually, follow up on because they are, you do get lots of pathogens, particularly in children. And GI, norovirus with C. diff isn't uncommon. It's down to clinical follow-up then. CT values, for virology, we have used them. So if you do get, for respiratory, if you do get lots and lots of viruses, I can go back and have a look and do some CT evaluation on it. Quantification very rarely used. We only use quantification for some of our transplant screens, EBV, CMV, that sort of thing. We only quantify those. And CT value, I think we're all aware, although CT values are the hot topic of the world, they are not standardised across systems, so a CT value on system A might be 32, but on system B might be 26. There's no standardisation. Unless there's a WHO standard, it's not standardised, so it isn't easy to use, standardisation for monitoring infections. But just be aware that they happen, dual infections happen, and they can equally be causing the syndrome. It's not necessarily one over the other. Some poor unfortunate person may have had one infection after another. That's life, It's just we're able to detect it now.
Hi doctor. What about the bacteria situations? If you have multiple infection or you have 3 or 4 bacteria infection, but what if it is dead bacteria? You go for any confirmation.
So in the data that Michael's looked at, they're not that common. The multiple bacteria are not that common. It's the viruses with bacteria that you see. So actually having multiple bacterial infections and is not as common as with the viruses. It seems to be a virology problem that we have rather than the bacterial problem. So you may see 1 or 2 infections together, and then you just go back to the culture. They will review the culture results, on those. But it's, like I said, it seems to be more of a virus issue.
Thank you.
Any other questions? Okay, so thank you so much.
Thank you.
Just before we go to our dinner, we would like to welcome Mrs. Chiara from Diasorin just to give us an overview about the molecular solutions in Diasorin. You can also check them here. They are displayed in this room. So please welcome Mrs. Chiara.
Thank you. Let me know what is okay. I can. And this is the mic. Okay. Good evening, everybody, and thanks. So I try to go on. Okay. And thank for being here with us this evening. For me, it's a very pleasure, and I would thank Virus and my direct colleagues from Diasorin to having invited me to this workshop. I would give you some highlights. I don't want to bother you with all our molecular solutions, but just to give you some important focus that we have and that they are really linked to the Dr. Moore presentations today. Just to give you just an highlights about what it is the molecular part of Diasorin today. So you know that we have acquired in 2021 the Luminex part, and now we have different. Different. It is a pointer also. No, is it a pointer? No. Okay, it's fine. Just to give you that we have some R&D department. One is based in in Gerenzano, and where is it? It is closer to our headquarters in Italy. And then we have, of course, inherited some R&D and facilities department about the manufacturing of molecular assays. You know that now laboratories are playing a very critical role in healthcare diagnostics. So I would show you this slide just to say that 14 billion lab tests are ordered annually, and with 70% of medical decisions are dependent of those results. And you know better than me how is important to give to your physicians affordable results, and the physician needs to be really educated also, and not only, but it is this result should be very reliable for the physician. So just to say that Diasorin is a partner not only for the lab managers but also for the physicians, because we, with our test, with our solution, we are covering a lot of clinical areas that are not only for the immuno part but also for the molecular part. Just to say that, so we have some instruments, some platforms. These are the tests and the clinical areas that we are covering with our platforms. We have there the Diasorin MDX that you can see in real life. And then we have the Verigin platform that is more a sample-to-answer solution for the syndromic multiplex test. And also we have the MarkPix with the NX databases that are able to cover also the syndromic part for a need, a high throughput need sample results. So in this moment, with the acquisition of Luminex, we can cover different segments that are the single-plex segment, and also the multiplex sample. So in this moment we are really unique. We are playing a unique position in the market because so we have several solutions that can cover your needs. Just to this slide would like to say that we are so Diasorin is a trusted partner, because if we go back a little bit to the beginning of the pandemic, we were able to develop the simplex COVID-19 test. That is a test that you can run on the Diasorin MDX, the platform that you see there. In just 1 month, just to say that, of course, as the other companies, but also Diasorin developed this test very, very quickly, and it was the first test FDA approved. And again, also we developed just to cover the customer's needs, again, and to take care about which is the needs of our customer. Also we developed the COVID-19 variant, just to give you some examples about the fact that we are taking care about our customers, but finally we have the patients that needs to have reliable results from our solutions. So we have again several solutions that we can propose to our customers and to support our patients. So we have the Diasorin MDX that is more suitable for routine and urgent testing, because you can get your result in 60 minutes. for different assays that we see later in the next slides. Then we have the Verigin, is a sample to answer multiplex solution, and also we have the MACPIX syndrome. It's a syndromic test for high urgent testing. Essentially, I would focus a little bit on the Diasorin MDX. These are the clinical areas that it is able to cover with the simplex assays. So we go from the respiratory infections to the meningoencephalitis, especially we will talk about the HSV 1 and 2 and VZV. That is very important, and Dr. Moore said before, and also we have the hospital-acquired infection and the herpes viride. It's very simple because the core of the technology of the Diasorin MDX is this disc that you can see here is called direct amplification disc. Why direct? Because you can load the primary sample directly onto the well of the disc, and so you can get after this, you can of course load the reagent mix, but after this you can get your result in 60 minutes or maximum 80 depending on the protocol that you are running. This is also again the clinical areas that we are covering, but essentially these are again the multiplex technologies that we have mentioned before, with the two platforms that are the Verigin with some tests that are the respiratory pathogen panel, the enteric pathogens, and also the blood culture. And again with the MACPIX we are able to cover a panel with for the respiratory areas, plus the SARS-CoV-2 extension, and also the gastrointestinal panel. And here below you can see a new platform that is coming, so of course further details will come in the next years, but essentially Diasorin is working a lot trying to cover really the customer's needs, and this is a platform that will be a multiplex platform with these assays in development. Again, the MACPIX, the clinical areas, and just to give you some highlights, on the Diasorin MDX we have the broader portfolio for the respiratory areas with the simplex COVID, the combo one, with which is able to detect the flu A and B and also the COVID. It is more suitable for a differential diagnosis during flu season or when a patient has flu-like symptoms. And a good thing is that these two samples could be run in the same disk. These are some highlights, and again, just to complete the respiratory barrier portfolio that we have seen, also we have the Bordetella. The Bordetella that is called simplex Bordetella pertussis and parapertussis, because it's able to detect both the pertussis and parapertussis, and it is a very highly differentiative assay since it is offering preparedness considering possible outbreaks driven by vaccination. This is also a study that has been published where I don't want to go into more details, but just to say that it was published from the Journal of Clinical Microbiology, and the conclusion is that the simplex Bordetella kit offers the advantage of a rapid and accurate approach for the detection and differentiation of Bordetella pertussis and parapertussis. And then we can go on with the detection and diagnosis of the meningitis and encephalitis that has been presented by Dr. Moore is very important. So just to say that we have for the meningitis and encephalitis, we have these two kits. One is the simplex HSV 1 and 2 that can be run on the Diasorin MDX. Important this kit because it has a double validation on the CSF and on the swab. The swab is a validation generic, so you can use this kit also for lesion locations coming from with the swab, from genital, nasal, ocular, oral, and the others. And also, it's important to say that CSF, is a very precious specimen, especially for all the people, but especially if you can load just 50 microliters of CSF, it's a good thing because you know that is a technique very invasive to take this specimen. So, and we are unique in the market for this kind of amount that you can load onto the disk. So it's very important. And in association, you can also associate the VCB. Again, here is validated for CSF, and you can load just only 50 microliters of this specimen. I would spend some words also on it is the same kit, so it's HSV 1 and 2 with the validation on the swab, and in association we have the simplex VCB validated on swab is another kit, but you can associate easily with this kit. Again, they can be performed together. And also I would spend some words on the simplex congenital CMV direct. Is an infection that could be transmitted from mother to the child. This specific kit is for the detection of congenital CMV. It is validated on saliva and urine. It is suitable for the diagnosis of congenital CMV in the neonates within 3 weeks. And this can allow the diagnosis of this disease, and in order to this infection, in order to avoid neurological sequelae that are very, very important in this kind of infection. And now I finish with the solutions that we are in development. So just to say that we are working hardly on develop new platform in order to follow always the trend and our customer needs, of course. And one is the Diasorin Plex that I mentioned before, and the second one is the point-of-care platform. With all of these our instruments, currently we are able to cover different segments of the market, and also with the future platforms that are coming. The point-of-care market, the low-medium centralized setting, so this means the medium and general hospital, and also the necessity of having differential diagnosis for some pathogens, and also we are covering also the multiplex solutions. We have multiple solutions to cover this kind of needs in some specific situations. So, going on to the point of care, that is a platform that will come in the incoming years. It's a PCR based, so it's very quick result you can get in 15 minutes. The main target will be for sure hospitals in the decentralized sites, also in the future physicians and pharmacies. It is a very easy to use and professional point of care platform, and also the first essays that will be launched together with this platform will be the flu A and B and then COVID-19. But we have other essays in our pipelines that are now under development with RSV, the Streptococcus group A, and the sexual transmitted infection. This is the Diasorin Plex. As I said, it's very important in terms of flexibility and scalability. It will be a sample to answer platform for the syndromic part, with an economic value based on the number of pathogens that you could could have, so you will be able to choose so the number of pathogens requested by from your needs, by your needs. And then we are also working on the new generation of the current Diasorin DX in order to have the instrument new. Nothing improved in terms of technology because it's working very well. During the pandemic, we have installed a lot of these instruments, but just to have an instrument fully integrated. And also we have improved some part of serviceability and upgraded supftware. And for me, is the last slide. I would thank you so much for your attention, and if you have questions, I'm more than happy to take them.
Okay, so thank you so much, doctors, for your attention. Thank you, Chiara, for this presentation. Actually, as we mentioned at the beginning of this lecture, the Diasorin molecular solutions are displayed here in the room. So if you want to have a look before going to the dinner, it's here. So we would love to explain more about it. Thank you.
Okay, so just I would like to thank the speaker, Dr. Catherine, and having also our partner Diasorin, as well as I want just to introduce also our partner, the end user. We are having them with us is LifeDX, having the CEO, Mr. Hussam, as well. Like LifeDX is our partner. We have many different solutions from virus with LifeDX, having many different technologies, and they are the first adopter for the innovation of Luminix Diasorin. Innovation having the MagVix to have the GI and respiratory billing for high workload. So I will just give maybe, I'm sorry, in the last second, if Mr. Hussam can just have one word to thank you.
Thanks a lot, Mr. Shweik, for the introduction, and it's actually a pleasure partnering with Virus to get the best out of the technology right now in the market back in our laboratory. And there in the beginning, when we started Live Diagnostics, the first challenge that we have is to identify people or suppliers who can work with us, not as just a normal supplier who just bring back the machine to our lab and just leave us in the nowhere. So we were actually choosing partners, and thanks to Mr. Shweik and his team who work with Live Diagnostics as a real partner, and he always behind the scene delivering the best out of the diagnostics technology to us to enable our end user from doctors and from patients as well. So right now, most of the solutions that you heard about today is available at Live Diagnostics, and also we are keep on introducing multiple tests using these platforms that will enable the end user and the decision makers inside the hospitals to get more insights for their patients. Thank you so much, and thanks for having me today. And for any inquiries about Live Diagnostic Services, our team is here. We have all the products and the brochures as well. Thank you so much.